This
tell us.
conference will now be recorded.
Thank you, Jake. Mr. Marshall, if you could be fairly precise and tell us a little bit about your background. I'm going to ask you some questions, and
Okay.
And we'll go from there, and then we can fill anything in. So, Jim, how old are you?
The age is 76.
76. And where do you live?
I live in Virginia, Alexandria.
Okay. Alexandria, VA. And what year were you first diagnosed?
Let's see, 2017.
2017. Okay. With a Gleason score of what?
7, 3 plus 4.
3 plus 4. And what was your PSA level when you were diagnosed?
Well, actually, that's a bit strange. Actually, I had a PSA in 16 of a 3.1, and they, let's see, in about June, they thought I had a gastrointestinal infection, and they did essentially a biopsy on a lymph node within the back, okay, and they found the, let's see, with the prostate cancer. So at that point, I did a PSA test, and it was 7.5.
Okay.
And then
now,
consequently a biopsy, essentially on the prostate.
Prostate, by the way.
Yeah, right.
There's only one R in it. Now, as I recall, you go to the VA, is that right?
Negative.
Oh, okay. So where are you treated?
Here, let's see, here, anyway, I'm a Kaiser person.
Okay. All right. Kaiser, Virginia, right? Kaiser,
Yeah.
DC. Yeah. Okay.
Virginia.
Virginia. Yeah. Yeah. I'm very experienced with the Kaiser system from California. And so, so you're still with Kaiser, correct?
Yes, I am.
And are you being seen by a urologist, or are you being seen by a medical oncologist, or both at Kaiser?
Yes and yes.
Okay. All right. So I pretty much know that your medical oncologist is not a prostate cancer specialist, because there's only about 3 of them that are, and they're all in California. That's the bad news. The good news is we'll tell you who they are, and they're accessible to you. So we can bring them onto, we can tell you who the Kaiser genitourinary medical oncologists are. And we know from previous experience in Atlanta and in DC and elsewhere that they're available to you to talk to, which can be very, very helpful. Before you began any treatment, given that we know that you had this biopsy in your lymph node, did they perform any scans on you?
Yes. They did a bone scan on me, and it was clean.
Okay. And did they do any other scans?
Negative.
Okay. So what was the initial treatment path that you selected? How did you start? How were you treated? Because from what I'm hearing, you were a 3 plus 4, but they found cancer outside the prostate in one of your lymph nodes, correct?
Yes. Okay. The lymph nodes essentially in the back. Okay. The big ones.
Okay.
So at first I was scheduled for the, let's see, for the chemo plus, okay, a Lupron shot, but then the study, and when the Latitude study happened to close, and they happened to publish, and a person like me could start on Zytiga. Okay, at the time it was brand new approach.
Right.
So at that point, I canceled them with the chemo. Okay, and I started the Zytiga plus and with the Lupron shot, and I've now been on it for 42 months.
And are you doing two prednisone 5 milligrams or 2.5 milligrams?
2 5s.
2 5s. Okay. Months 2 by 5. 2 by 5. Okay. So tell us what has happened to your cancer since then.
Tell me, I don't know, because I feel great and I've been active, and with the PSA is 0.01, okay, and the side effects, and I can get rid of those, okay, if I happen to exercise a lot, okay, and I then essentially hydrate.
Right.
And so other than that, and I feel great.
And they haven't done any scans on you since you started treatment?
Negative.
Okay, well, if it were me, I'd be asking him to do that, even though just to be checking, but it sounds like
Okay.
everything's working. How's your and your testosterone levels are where?
0.
Okay. Okay. Have you had any genetic testing done at any time?
Yes, I did. I just had it about, let's see, about a month ago, because I started to talk to the doctor about the next drug, okay, it's in the sequence. And she happened to him and haw and him and hawed. So then I suggested a few, and she said, oh no, that one's only for, okay, a gene, thing. So I did get the gene testing done, and I do have a defective or a suspicious ATM gene.
Okay. So there's some sort of a mutation, and was this the inherited test that they did?
They did the test. Well, inherited, I'm not quite sure what that is. They did the test. It's on the blood, okay, and a portion of the prostate cancer itself.
Prostate.
Prostate, yeah, excuse me.
So they tested a portion of the prostate itself. So they took a biopsy.
They used the existing ones.
Okay, so they used the existing biopsy to test tissue, and they also did a blood test. So it may well be that they did both. What's called
Yes.
a germline test to see whether you had a inherited mutation, and they did a somatic test to see if you'd made any mutations. Did they tell you whether the ATM was inherited or if it was somatic?
I would have to go back to read, the report. It's supposedly something called a Prostate Next, okay, and it's a registered trademark, and they check for 14 items.
Okay, so that's Prostate Next, and that would probably be a germline test. Well, I don't know. I'm not sure.
Right.
I don't want to guess, but you need to know, because if you made it yourself, you can't pass it on. If you did not make it yourself, you can pass it on, or your siblings may be susceptible to the ATM mutation, and it's kind of important information. So one thing that I really wanted to cover with you, because I know that you were of the opinion that this wasn't an option, is that today with metastatic cancer, we do treat the primary gland. We didn't used to. 10, 15 years ago, it was rarely done except at Mayo and occasionally at Memorial Sloan Kettering. But today we do treat the primary. And on this call right now, I'm looking at there are at least 2, if not more. Forgive me if I'm not seeing you all, but there's at least 2 men who have had their primary gland treated.
Okay,
Nothing wrong with that.
Can we mute Rusty? Thanks. So it might be helpful just to start this conversation. If you want to ask any questions, maybe you would like to know about the options for treating the primary gland.
Oh, absolutely. You know, exactly what
Okay.
what a type of treatment.
Okay, Herb, since you just finished, since you're all done and treated, most recently, you're probably our most recent person. Herb will tell you, and Herb was diagnosed de novo metastatic with more than 1 lymph node. Herb.
So I was diagnosed metastatic to the bone and have been on essentially what you were on, abiraterone and Lupron, for a little over a year. And based on sort of reading and whatever and encouragement from this group, I went ahead and decided that it's probably better just to irradiate the primary tumor and see, you know, let's get rid of that and then we can worry about anything else later. And so I used a radiation method called SBRT, which is stereotactically directed radiation at Georgetown. And obviously we don't know the results yet, but as of a week and a half, I don't feel anything. So that's, I think, you know, I would have no problem recommending focal radiation to the prostate in the case of metastatic disease.
And let me ask one of our other moderators who resisted that treatment for a long time, but eventually decided that he was going to go forward with it. Len, maybe you can throw a little light on this matter for Mr. Marshall.
Yeah, Jim, I was diagnosed in 2014 with the Gleason 9 and metastatic to lymph nodes. But at the time, as Rick said, even at MSK at that time, they were not recommending, or at least my particular medical oncologist was not recommending treatment of the primary. So they just put me on hormone therapy. But at the urging of Rick and some others at ANCAN, eventually 2 years later, I went against the MedOnc's advice, and I had radiation to the prostate and the whole pelvic girdle. Now, in your case, you're practically undetectable. I don't know that there's an urgency to get radiation therapy. Anyway, let me just back up and say I had IMRT, you know, which at that time was most widely used radiation for the prostate. But I would recommend what Herb had because it's far fewer sessions and usually associated with fewer side effects.
Let me go, Len, let me respond to what you just said also, which is, again, given your extremely low PSA value and testosterone level, I'm not seeing the need for radiation right now.
Yeah, I think all we're doing is just pointing out to Mr. Marshall that it's an option. That it's an option. because I
Right.
know that he didn't think it was an option.
Well,
No, I did not.
but if you're thinking about talking to your oncologist about what would be next, certainly I'd put that on the agenda.
Okay, I thank you. And that was STRT or SRT?
SBRT.
SBRT.
Yeah, it stands for
thank you very much.
stereotactic body radiation therapy.
Radiation.
Stereotactic body radiation therapy. Before I forget, if it were me, I would want to pull into the discussion one of the docs that I know is very well qualified in prostate cancer treatment, medical oncologist, well qualified. I would suggest either Andrea Hartstark, Harzstark, who's in Oakland, used to be at UCSF. And the other doctor that I would recommend from Kaiser is Wan Kim, Wankim. They're both just terrific, both of them. And I think one is in, he's on the peninsula also in the Bay Area. He's not in Oakland, but either of them, if at any time you want to bring in a specific doctor, and the likelihood is your medical oncologist isn't even going to know that expertise exists, but they are both really, really good. You don't really need it right now because everything's under control, but if you ever do, those are two doctors that you can rope in through the Kaiser system, so you don't have to go outside.
Right. I thank you very much. I did not know that.
So do you have any questions for us?
Not right now, no.
Okay, well, keep coming back. Every time you come in, you'll learn a little bit more. There's a lot of guys with a lot of different experience in here. Yes, questions from anybody else? Sorry. Anyone else in the group want to raise an issue with Jim? Okay, then we.
I'm sorry I'm late. I'm just surprised that Jim has not had a full body CT scan to see if he has the metastasis in other places, maybe an Axumin scan. Hartstark would have demand that. In fact, for me, Hartstark, when my regular scan didn't show the right thing, she had me do the Axumin right away because she figured she wanted me on Zytiga. And
Yeah.
Sure enough, the Axumin works. So she should, I don't know why I'm going, but why not a full CT body scan?
Okay, fine. I will suggest that to her.
Okay, and then if she wants to bounce it off Dr. Hartstark, she should. The thing is, you don't have your PSA is very low, meaning you're still castrate sensitive. It's going to be very hard to do a scan right now with such a low level of PSA. And so the only way that we really could see what's going on with you is for you to take a vacation, to go intermittent, and to allow your PSA to climb to wherever it might want to get to. And once it gets to around the level of somewhere between 0.65 and 1, you're going to be a good candidate to do a scan. But, if you talk to the doc right now, the doc's likely to say, we're not going to see anything. And she's right.
Right,
So,
okay.
So, that's one of the issues that you've got to weigh up. But we may be able to see something there and see if there's anything, and it's just being controlled right now, before you become castrate resistant, which of course we hope that you won't for a very long time. All right, I've got to move on. Thanks for your comment, Jeff. It was worthwhile.
Yes, thanks very much, guys.
Let me go to Mr. Wallace. Mr. Wallace, I don't know anything about you, so I'm going to go through this little questionnaire that we do here, and by the time we're done, we'll know, we might even find out what you eat for breakfast. How old are you?
I am 83.
83?
Yes.
God bless you. And where do you live?
I live in Alexandria, in the west end of Alexandria, Fairfax County.
Another one? Bingo. Oh my gosh. Alexander, do you guys know each other? Mr. Marshall and Mr. Wallace, do you know each other?
Oh, I don't think I've ever met Mr. Marshall.
No,
Okay, maybe you should do. And when were you first diagnosed, Robert?
I was diagnosed in December of 9.
September 09, did you say?
Yes.
Okay.
No, December of 9.
Okay. All right. Well, 2009 is close enough for government work.
Okay.
And you're in Alexandria, so you know all about government work, right?
Of course.
What was your Gleason score and your PSA level at diagnosis?
My PSA was 0.3. And I had an intermediate score of 3+4 on one core, 10% of one core. The reason my PSA was low, I've been on Avodart for the past 7 or 8 years for controlling BPH.
Okay, so let me just verify with you. Has your cancer gone metastatic?
I have relatively little problem with my cancer. It's basically started out at 0.3. A month later, I went to 0.2, and it's been less than 0.1 the past 10 years.
Okay, so
I'm here as a tourist. I'm dealing with a bunch of guys that have all kinds of bad diseases, and I'm interested in what other people are doing.
okay, so what I would say is this, because there's no reason to get into your situation because it doesn't pertain. But you're very welcome as a tourist. You're very welcome to bring the other guys to us, and I would very much encourage you, especially with 3+4 and one core, to attend our active surveillance group, because there is a lot of debate in that group as to what they should do and whether they should intervene with 3+4, and you would be a very good example. Let me ask very briefly, my active surveillance moderator whether he thinks that would be a good idea for Mr. Wallace to attend our active surveillance group.
I have been treated with pararectally with 160 seeds, and that is the only treatment I have. And so it has been successful now for at least almost 11 years now.
Okay, so you did have low dose brachytherapy. Well, look, in that case, why don't you're welcome to attend this group. You're welcome to attend Jim's group, and Peter Kafka. Would you like this gentleman to attend your group too?
But I have already attended Peter's group last week. So,
okay. All right. Well,
there's no issue. You shouldn't waste any time on me.
Okay.
Other people.
All right. We'll move along. Peter or Jim, did you want to say anything to Robert Wallace before we move on?
No, just anybody new to the call, please put your email in the chat window so we can send you reminders for these meetings.
Right,
Okay.
but make sure you tell us which meetings you want to be reminded for.
Oh, I set up a profile.
Okay, perfect. All right.
I was proactive in that, and
Good job. Good job. And I know for a fact that we have Jim Marshall's. That's why I didn't ask him, because I know Jim Marshall's already in the list. All right, moving right along. Let's go to Rick Medley. Rick, do you have high risk recurrent or metastatic disease?
Yes,
Good. Okay. You're in the right place. How old are you?
71.
71. Okay. And where do you live, sir? Don't say Alexandria, Virginia, please.
I live in Culpeper, Virginia.
Where? Culpeper?
Culpeper, Virginia.
Okay. Well, I guess this is the day for Virginia. And what year were you first diagnosed?
1999.
Woo! Okay. We like you guys. What was your Gleason score when you were diagnosed?
3 + 4.
Okay. And your PSA?
It's around 7.2.
Okay. And where were you treated?
I was treated in Richmond, Virginia by a urologist.
Uh-huh. It's so funny you say that, because one of our most favorite people, Jerry Deans, lives in Richmond, and he also was diagnosed in 1999. And his name was going through my mind as you said that.
That's where I lived in 1999.
Okay. Well, Jerry was Jim Schrait's vice chair at us too, and he's become a good friend, and we've navigated him for a while. So, do you have now well, let me skip that for a second. What was the first course of treatment that you did?
In April of 1999, I had a radical prostatectomy,
Okay.
which I think was one of the worst decisions of my life.
Okay. I see somebody smiling there. Go ahead.
The next morning, the urologist came in and he said, I have good news and bad news for you. The good news is you almost bled to death, but you didn't.
Mhm.
And this bad news was, he said, they found some cancer cells at the surgical margin.
Okay.
And so the PSA rose during the rest of the year 1999. And in January, February 2000, I received the maximum dose of external beam radiation as best as they could do it back in those days.
Yep. Keep going.
That gave me chronic rectal problems
Yeah.
and bowel problems.
Yeah.
I sort of went into remission for a number of years after that, but I also tried different forms of alternative therapy treatments. And so I'm not sure which, exactly what it was that kept my PSA down, but when my PSA started rising again, I was put on Lupron intermittently, and then I've been on Lupron since 2014.
So in other words, you did certain treatments, whatever they were, between 2000 2014 that kept your PSA relatively low, and then in 2014, how high was your PSA?
I don't remember exactly, but I'll guess it was around 11.
Okay, so when it got to around 11, I mean, it wasn't in the hundreds or the thousands, because sometimes we find guys that do
No.
that. You know, they'll wait and they'll wait and they'll wait. But so it got to around 11, and then you got on to intermittent hormone therapy since 2014, and
Right.
and how's your PSA been doing? And have you done anything more than just Lupron?
Yes, I've done more than Lupron. The PSA was pretty much under control with the Lupron until my urologist, a scheduler employee, called and said the urologist had a meeting or going on vacation or something and rescheduled me. It was a non-medical person, and that put it past the expiration date of the Lupron.
Mhm.
So about 3 months passed. So when I went in, my PSA was in, let's see, this was August of 2017. I went into the urologist and my PSA was 24, and I had significant pain in my spine at T10 and T11.
Mm-hmm.
And it was that delay without the Lupron that caused it to, I think, flare up.
Yeah.
So he said, well, this is after I've been with this urologist for 17 years. He said, I think you need to go seeing an oncologist. So I should have, in retrospect, I should have immediately switched to an oncologist right after the surgery. And that's what I tell everybody now.
Yeah,
Just switch to
what we tell everybody, Rick, as well. But keep telling your story. I'm so glad you're relating, so people can hear this.
So I moved to Arlington, Virginia from Richmond. My mother was in her late 80s and starting to show signs of dementia.
Mm-hmm.
So I moved in to take her. My father had passed away, and so I needed to switch my physician network from Richmond to Arlington, and I started seeing Dr. Robert Christie, a generalist oncologist at Virginia Hospital Center.
Mm-hmm.
By the time that I got in to see him, 1 month after I saw my urologist in Richmond, my PSA was at 34.
Okay.
And the pain was getting worse. I was treated with CyberKnife radiation.
Mm-hmm.
That was successful. I had back spasms for about 6 months that gradually diminished, but the pain went away, and that worked quite well at that particular area. My PSA went down to 0.12 in the following year.
Just with the resumption of the LHRH, nothing additional?
Correct.
Okay.
Dr. Christie wanted me to start on chemotherapy right away, but I'd talked to enough people that had been on chemotherapy that it didn't sound like it was going to help me.
So they saw T10 and T11. Was the cancer anywhere else?
The bone scans showed what they call sclerotic lesions up and down my entire spine,
right,
in different spots. Some of it looked like it might have been eaten on by the cancer in a little area and then stopped on its own, or I guess my immune system stopped it at that point before it hurt.
Okay. So I have to move you along because I know we're a little pressed for time here. This was back in 2017, and they did the spot radiation, and you're down to 0.12. What's happened between 2017 and 2020?
The PSA rose, and it got up to 30 in June of 2020,
Okay.
and new pain, which was diagnosed as metastasis at S1. And that was treated in June of 2020 with cyberknife radiation. And that seems like it's mostly taken care of, but I have some pain now at kind of in my left hip socket, maybe down the spine
Right.
in the
So
area.
let me ask you two questions. The first is, what are you still just on LHRH, or are you on any other drugs?
I've recently been approved to start Zytiga, but I haven't started it yet.
You haven't started yet. And are you still seeing Christy?
I started in July of last year to see Channing Paller at Sibley, and that's when I learned that she's a prostate cancer specialist, and Dr. Christie is a generalist, and he couldn't answer my questions. So I'm in the process of switching.
Right. I think I've heard her name before. Herb may know. Herb, who Herb doesn't know her. I think I've heard her name. I mean, the first thing, of course, we would have said to you is get your ass over to a medical oncologist, because these damn urologists milk you for the Lupron when they shouldn't be treating you. And the
I
second
found that out after 17 years.
no, there you go. And the second thing is that if you're going to see a medical oncologist, make sure it's a genitourinary medical oncologist. Who you're now seeing, I don't know Channing Power. I think probably somebody here will look her up, but I'm not surprised you moved her in July. I am a little bit surprised it's taken her 6 months to decide to put you on the abiraterone. What questions do you have for us?
Let me fill you in on the most recent things. As my PSA was continuing down from the cyberknife treatment in June, and it was down to 9.9 in December, and in January it went up to 15.2. So I have an appointment to get a PSA blood draw Thursday of this week, and then an office visit appointment on Monday, and we'll see what's going on at that point.
So September it was 9.9, now it's back up to 15.2, right?
December
Okay.
was 9.9.
Sorry, December was 9.9, and so in the last month or so it's gone from 9.9 up to 15.2, right?
Correct.
All right, let me throw it open. That's a pretty good story. Who would like to pick it up? Herb.
Well, I guess the first thing I'd ask is, have you had any recent scans to try to localize?
My last scans were 6 months ago, 6 months ago in September, and I anticipate I will be scheduled for scans later this month after the office.
What kind of scans did you have?
A bone scan and a CT scan.
Uh-huh. So one of the things that I think Hopkins is doing it, would be a more targeted scan to try to localize where your cancer would be. And I'm referring mostly to a PSMA PET scan, or I suppose an Axumin.
I requested that last week and was told that the only PSMA scan machine that they knew of was in San Diego at UCLA Medical Center. Now, I've also heard that there was another PSMA machine at NIH that was used in some trials last summer.
Well, it's still going. I mean, I'm at NIH, and yes, that machine is still there. But the only problem is that the campus is essentially closed because of COVID. So that's what would prevent anybody from getting into those trials.
But you know, with your level of PSA, an Axumin scan would probably be
Right.
almost as good.
Either one.
And you could get an Axumin scan very simply. And I think it would be helpful as a benchmark. I mean, I'm not sure that it's going to change treatment options greatly, other than to maybe point out that maybe chemotherapy, if you have extensive Mets, maybe chemotherapy is the right move right now and something you want to be discussing. Where is Dr. Powers?
She's at Sibley
She's
Hospital.
at Sibley. And she's at Sibley, and I think probably the main campus as well in Baltimore.
Okay. So, you know, I definitely think if it were me, I would be seeking a second opinion at Hopkins from somebody like Antanarakis. Because I'm just, you know, I question, you moved here in July. I'm looking at what's happened since July. The PSA's been high, and I don't get.
Yeah, she's my second opinion from Dr. Christie at Virginia Hospital Center.
Yeah, well, I dumped Dr. Christie if it were me right away.
That's close to doing that.
Yeah, so I mean, I dumped Christie, and I mean, you really want a good GU med onc, and there are a couple.
What was that machine test?
Axumin, 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 and it's an FDA-approved scan for which you're PET scan for which you're eligible, or CT PET scan, and it's not quite as defined as a PSMA scan, but at higher levels of PSA, it's going to make a lot less difference because it doesn't have to be as sensitive. But I think the issue is, and this is really what I would like to hear somebody like Antanarakis' view, is what the next treatment should be. Is Zytiga the right treatment? Sounds to me, you know, the Latitude study, which Jim Marshall's very familiar with, would say this sounds a lot more like high volume Mets. And if you're willing, then chemotherapy might be the right option. So anybody else?
I just looked up Paller, by the way, and read her bio. She's got incredible credentials. And so my sense is, if, you know, what we're recommending would be, and I think I don't have it, the t-shirt, is basically to bring this to her attention as soon as you can. Bring her these questions. But Rick, I don't think I'd be afraid of using her.
But why wouldn't she have ordered an Axumin scan? You know, PSA 30, July. Why didn't she order an Axumin scan back in July?
Where are those machines located?
Everywhere, across the country.
I don't think Virginia Hospital Center has one.
No, but Hopkins must have something.
It's a PET scan with a different drug.
Right.
And Herb,
it's a little more than that, Jeff, because you have to be within a certain radius because they have to deliver the agent. The agent gets sent in, so it's a little bit more fancy than just saying it's a PET scan with a different drug. I mean, you have to go to certain places to get it, but you can look on the Axumin website, Blue Earth Diagnostics, and you can find out where the closest is to Culpeper, Virginia.
Okay, Herb, if there's next time you converse with anybody at NIH about the PSMA machine, ask if there's any way that I can get in there.
I don't think there is because Dr. Geller, who runs a lab at the NIH, we should tell you, has been trying to access that technology for some time. So I just...
Well, I mean, I did have one scan initially at diagnosis, but they basically are saying not we're not going to do it again, even until it opens up.
Yeah, I just
Okay.
want to add that as of next summer, both the Denovo Shar Center in Fairfax and Reston will have a brand new PSM or brand new PET scanner with the latest technology. So if you can wait that long, they will have brand new machines.
Just as a quick question, Rick. Robert, did you say you had a PET scan already?
I've not.
Because I was going to say, as we're talking about PET Axumin, PET PSMA, and so on, but many facilities, to my understanding, have PET scans available, and so it would seem to me that that would be a first step, because it's not the most absolutely sensitive technology that's available, but that might not be appropriate. Something more specificity might not be the next step.
I did just look this up, and Sibley does have Axumin scans.
Okay.
I mean, to me, that makes it even more strange why he wasn't referred there initially. But look, I mean, if Herb thinks that Dr. Power is a good option, fine. But I mean, I would, if it were me, I'd get rid of. I know I would get rid of Christie, and I would probably want to get an opinion from Hopkins. So, anybody else want to contribute before we move along?
What did you use to manage your pain?
Nothing.
Ouch.
Okay.
Yes. Ouch.
Rick, when is your next appointment to talk to her, to talk to Pallor?
I don't have my next appointment with Pallor. The next one is on Monday with Dr. Christie.
I would say you should make an appointment. I mean, I agree with Rick. We need to have Hopkins and we need to have a GU oncologist, and we can't waste any more time. I mean, I think I would dump Christie, talk to Pallor, bring her the questions that we're asking you, and see what she says.
Okay. I have a way to communicate through the software. My chart. I can send her questions and she responds.
Okay. So I think that's a great idea, and I would get a second opinion. Hopefully it's covered under your insurance, but I would see if you can get a second opinion. I would send you to Emmanuel Antanorakis. If somebody could put that in the chat window for me, I'd appreciate it. Emmanuel Antanorakis. There are several options. A couple of them are not so good. We tend not to refer to Carlino because we've not had the best experience with him. But we do like Antanorakis a lot. And
I did ask.
Go ahead.
I did ask Dr. Pallor how come she ended up as a prostate cancer specialist, and she said it was a relative of hers had died. I don't know if it was her father or her grandfather.
Okay. Okay.
I
Well,
got a quick question, guys.
She seems committed.
Okay. Well, if you like her, stick with her. But it just seems so strange to me that that she hasn't done some standard things since you saw her in July. We're already 6 months on, and that's why I'm having the issue. But there could be a lot of reasons why. All right, guys, we're gonna have to move along. I'm so sorry that we're rushing through this. We've got at least 3 other guys. Fred Romero, I hear you have issues with pain. We're probably going to be talking about pain between now and the end of the call. I would ask all of you who are new to come back on Tuesday. It's pretty rare that we get 5 new guys all at one time, and we have to give some time to the guys that come in regularly. So you'll have to forgive us, but you will have priority next week. You be assured. I think next week is Peter. Right, Peter? Aren't you in the chair next week?
Yes, next
Okay.
Tuesday, a week from,
Okay.
tomorrow.
Okay. So now I am oh, and I just want to point out to everybody that about the chat window, in case you don't know about it. There is a little bubble in the top right-hand corner of your screen if you're on a PC. I'm not quite sure where it is on a Mac. It's probably somewhere close to that. If you click on that bubble, it'll open up a chat window, and there's a bunch of information that's going into the chat window. I see Joe Blanchette has put in all of the docs. I said Carlino, I meant Carducci. Carducci, we kind of try to avoid. Sam Denmead is a good guy. Emmanuel Antanarakis is probably the best. Markowski, we don't know. Channing Paller has got a Hopkins address. So I'm
You
confused.
said Hopkins, and she's
No, she's with
there with the
Sibley.
rest of them.
Sibley Hospital was bought by Johns Hopkins.
Oh, okay, well, all right, so she is, all right, well, then you're fine. Then you cannot go to Antanarakis.
Rick, I don't think there's an issue. They're really, you look at her
Okay,
credentials at Hopkins.
okay, sorry about that. I wasn't aware that Paller was a Hopkins doctor until that was just put in there. So forget the Antanarakis. See what she says. We can come up with a couple of other names for you if needed. I'm going to go through everybody on the list who is returning and see who needs time tonight. Okay, and we'll start with Jake. Jake, anything for you?
No, thank you.
Okay. Herb, anything for you? No. Peter, anything for you?
Nothing tonight.
Okay. Peter M, anything for you?
No, thanks, Rick. I'm good.
Frank, anything for you?
Yes, quick update.
Okay. Tracy, anything for you?
Nope, I'm all set.
Okay. Steve Linett is Steve Linett, please come back, Steve Linett. We will listen to your story next week. Jerry Pelfrey, anything for you? Jerry Pelfrey?
Only an update.
Okay.
Only an update if you have time, Rick. Otherwise, we can do it next week.
I got you. Joe Blanchette, anything for you?
One quick question.
Okay. Rusty, anything for you?
2 minutes.
Okay. Was that a no? Was that a no? Did anyone else catch that? Was that a no from Rusty?
You said 2 minutes.
2 minutes.
It was a yes.
2 minutes. Okay, Paul Frieder, anything for you?
Nothing for me. I'm good.
Thank you. Jeff Marchi, anything for you?
No.
Les, anything for you?
No, thank you, Rick.
Okay. Ben, anything for you?
No, thanks, Rick.
Dennis C, anything for you?
No, thank you, Rick.
Okay. How about Dennis M? Anything for you? Dennis McGuire? Okay, he might have left. I saw him. I did see him, but he's no longer here. Carl, anything for you, sir?
Yes.
Jimmy, anything for you today?
I demand 35 seconds.
Okay. All right. We're putting the clock on you, man. Sylvester, anything for you?
No, thank you.
Okay, Lawrence H., please come back next week. John A., anything for you?
No, thank you.
Pat Martin,
No, thank you.
okay. Larry Fish,
Wow, what a surprise. No, thank you, Rick.
Len, anything for you?
Niente, nothing.
Okay, Dennis McGuire, I see you again. Did you need time? Oh, we can't hear you. That's why. That's the problem. I can't hear you. Give me a thumbs up or a thumbs down if you need time.
Looks like he froze. Oh, there he goes.
No, he doesn't. Okay. All right. Where was I? Len, you said niente. Jeff Hancock. Jeff, are you, have you been on the call before? Your name is familiar. Do we not hear anything from Mr. Hancock? He may have left. Okay. Pete Nickering was in the wrong meeting. Fred Romero, please come back. Jeff Marchi, anything for you tonight?
For the second time, thank you, no.
Oh, okay, sorry, I did ask you before. And yes, I've got some people in twice. I thought I did. And then Jimmy, I've got in. And Russell Hoover, anything for you? Russell, anything for you tonight?
Answer the question.
Okay, so Russell's muted. I don't see him. So is there anybody who is here not to audit?
Mark
Oh,
Finn.
Mark Finn. Jesus. Sorry, Mark. Mark.
That's all right,
Finn.
Rick. You don't have to call me Jesus around other people, but that's okay. Yeah,
Yes,
I can get.
we want to talk with you. We want
Well,
to talk.
we could talk at the end, if not.
No. People should hear what you're doing. It's good. It's good information. All
But
right.
thank you very much for the compliment. I'm humbled.
You. Anybody else that I missed? Okay. All right. We're going to move through at a rate of knots here, and we're going to start with Mark Finn, who can tell us a little bit about this trial that I mentioned in my reminder letter. Go ahead, Mark.
Just very quickly, and then I will answer any questions people have, if I can answer them. First of all, just as a reminder, I have stage 4 prostate cancer, gone through prostatectomy, docetaxel, Provenge, and SBRT for a T6 tumor, Xgeva, and Xgeva is starting to lose some of its effectiveness. So I started around 1 with a 0.5, I think, for PSA. Now I'm around 6. And so standard of care would be maybe a try at Xtandi, and then would think about some other things like doing chemo again. I'm going to be entering a clinical trial at the U of C. It's one of, I don't know how many sites. It's a many-site study. It's kind of referred to as the ARROW study. Rick communicated, I believe, the National Cancer Study number if you're interested in the details. So it will be a 2/3 people receive the medication, 1/3 continue on Xtandi or start taking Xtandi, whatever the case might be. And so right now I'm just in the preliminary pieces of it. It might be an appropriate, there'll be like 15 people at the University of Chicago that are in the study. So if you're in the Midwest area, that might be an option for you, depending upon the particular case. There are other studies around the country, and I will know probably after the scans this month whether or not I'm in the number one, finalize that I'm in the study, and then number 2, At that point, they'll determine whether I'm in the 2/3 medication arm or whether I'm in the just the Xtansy enzalutamide. That's it.
Okay. Herb, do you want to just talk a little bit about this study? Because I know you did look at it because
Yes.
you were kind enough to respond.
Right, so it's basically targeting radioactivity to the tumor using, instead of an antibody, is using a chemical that links to PSMA. So, and the advantage of this method, it's supposed to be that because antibodies are big, they have trouble getting to places, whereas a small molecule can get into the tumor better. So it's similar to the lutetium PSMA, anti-PSMA antibody, but instead it's using a ligand and it's also using iodine-131, a different radioactive emitter to get to the tumor. And at least in some of the early studies that have been published with just using it alone, it had some efficacy in waterfall plots. So there is some data from earlier phase 1 and 2 studies alone, and now they're using it either in combination with enzalutamide or versus enzalutamide alone. And that's the trial.
So
2/3 will get the drug, 1/3 will get enzalutamide.
So once more for all of us, what is unique about this? What separates this from the lutetium PSMA studies that we've heard about, or the Actium,
Okay.
etc.?
What is special? The things that make it different are, number one, is a different beta emitter, iodine-131, which is
Right.
they have lots of experience with iodine-131 because it's been used a lot for thyroid, and it also means you've got to take pills that you've got to take iodine to prevent any damage to your thyroid. And number two, the big difference is the ligand. The ligand is a small molecule that was synthesized specifically because it binds to PSMA versus an antibody, which is a much bigger molecule. So it should have theoretically better tissue penetration. And it should be easier to get to the tumor.
Okay.
So those are the big differences between lutetium attached to like the J antibody versus iodine-131 attached to this chemical.
Okay, got it. Mark, do you have any questions for Herb?
No, I mean, we'll see. I mean, the first thing will be to just determine which arm of the study I'm in, and that'll make a difference because if I'm in just the enzalutamide only arm, I feel doubtful that I'll be in the study very long. So I'll probably drop out because I would expect my PSA to continue to rise. So I'll have to look at other options. And so I made this clear to the people who are managing the trial, and they understand that. So
yeah, I mean, I looked at the consent form and it said you can drop out any time.
Yeah, and I think the piece that Herb was discussing is that this Progenics, which I don't know whether Progenics has anything to do with Provenge, but anyway.
No, it doesn't.
No, okay, but Progenics is basically they developed this molecule, and so it's a proprietary molecule. So they're hoping that this will be a next step in something that can actually deliver the payload to the prostate cancer cells.
Okay. Okay, any questions, anybody, about this ARROW study that you would like to raise? And it is throughout the country.
Yeah, I don't know how many sites. I could figure that out. Herb might have looked at that when he was doing the background on it, but it's on
about 15 or 16 sites around the country.
Yep. Okay, so we're gonna keep moving, and with that hat on, Mr. Fabish, it looks like you're into chemotherapy.
Yes, quick update. I got my 4th Firmagon injection. My PSA continues to inch down. I'm now down to 0.53. I started 4 months ago at 2.82. I just had my second chemo treatment Thursday with docetaxel. And this one is less eventful than the first one. I had a lot of joint and bone pain with the first treatment. So they made a few adjustments on this treatment. They lowered the dose a little bit. And they also started me on at night on some tramadol for the pain. And that has helped a lot. The biggest problem I've run into with it is my taste, my tongue and my taste. And it's all crazy right now, but that's the way it is. So I'll be due up for my third treatment. I'll be halfway through. Both my wife and I did get this past Monday our Pfizer first vaccine shot, and I coordinated that with my oncologist, and they wanted me to have it 72 hours ahead of my chemo treatment, which I was able to do. So everything else is moving along. It's doing okay. All the blood tests are showing good. So I'm encouraged.
Who might have some tips for Frank regarding taste? And getting rid of that awful metallic taste that we know comes with chemo. Anybody
Well,
anybody have any experience?
I have some compassion for you. I don't know if I can give you a way out. I mean, yes, from this point on, everything will taste like barbecued aluminum foil. And the good news is that it will pass. Once you're done with the chemo regimen, your taste will come back. But you're in for a crazy ride. But if you, just kind of find some bland food that you can, like white rice or something like that you can deal with, because you might have some other issues, intestinal issues, this and that, and the other thing, nausea coming along. I mean, you're about to enter number 3. It'll get more intense, but you'll do okay. You'll do okay.
Frank, you might want to try butterscotch pudding with a plastic spoon. Work for me.
Yeah,
I'll try it. I'm up to anything.
Yeah.
Yeah.
I drank tons of V8. I never drink V8. But while I was in chemo, that's about all I could have. That and pasta.
Well, the other crazy thing is that, and I don't know if this has happened to others, the water tastes salty. That's crazy. But it tastes salty. And so again, these are just the things that you experience with your senses, and it's just all I'm focused on right now is 88 days, and that's what I'm focused on right now.
Frank, Dennis's point about using plastic cutlery is a really good one. I've heard that from a lot of people, that try to avoid during this time, try to avoid metal cutlery. It might help.
Okay, I will give that a try to see that and see if it works.
Yeah. Any other issues that you'd like tips on from experience on the call?
I wanted to say one thing.
Yes, go ahead, Larry.
You can talk about exercise. I actually found that if I did more gentle exercise, it helped with my taste. It helped with my eating. I would try to do really an hour, very easy on an elliptical in the morning, and then wait a little bit, and then I would have breakfast. That was soft-boiled eggs, pasta, rice, ravioli. Go with the easy foods. I'm a crazy spicy eater, so I couldn't eat anything spicy. And I just did exercise and took it easy with the food, gentle. And exercise seems to help everything.
Thank you. Thank you. Anyone
Frank,
else?
I have something to say.
Are
Yes.
you doing anything to abate the possible neuropathy at the end? You have ice water that you can put your hands in, or an ice cap for your head or anything like that? I used an ice cap on my head, and I think it helped because I've got very minimal neuropathy, just a little bit in the balls of my feet, nothing in my hands. So any tricks you can do, look it up, and there are things that you can do to abate that.
Jimmy.
Yeah, I just got one thing. This may sound strange, no more strange than butterscotch pudding or anything else, but I found that all familiar foods were disappointing. So I ate as many unfamiliar foods as I could, which just tasted weird. So that might not make sense, but I found that if I ate the things that I liked, I didn't like the taste. But if I ate stuff that I didn't usually eat, then I kind of broke even. The other thing is, I always say whenever exercise is mentioned, every single treatment I had, every single side effect was mitigated by exercise, including the chemo. I'm pretty convinced of that. Do whatever you can. More is always better, if you can. I know it's hard.
Okay. Well, we gotta move along. But Frank, I hope we gave you a few good tips here.
Sure did. I always pick them up every meeting.
Great, great, and we'll look forward to see if any of them were effective in the next meeting. Jerry Pelfrey, give us a quick update.
Okay, just real quick, about a week and a half ago, I met with my regular oncologist in Tucson instead of my medical oncologist in Mayo. And quite honestly, my MO in Mayo wanted him to do an EKG and an ECG. So he did the EKG, everything's fine. Sent me to the cardiologist for the ECG, and that's come out fine. Everything's fine. And my blood work and everything is right in line. I'm still, as far as Quest goes, the lab, you know, they only go to 0.1. So I'm still less than 0.1. Here locally, the last time I did it, I was at 0.02. So I'll check in another month locally at my lab. But my report is everything's fine. And I'm just knocking on wood and hoping it stays that way.
How's Debbie? We haven't seen her. Tell her to come on the Caregivers call tomorrow. Command performance.
I can only ask her.
Yeah, that's all right.
It's just up to her, right?
Okay. That's okay.
All right.
You should all know that when Jerry first came to us, his PSA was over 3,000. And so he is doing remarkably, remarkably well. And we are also thrilled. And when he talks about getting something done, test done locally, he lives in San Carlos in Mexico and comes up to Tucson for his treatment. Any questions for Jerry?
How long a drive was it, Jerry? How long a drive was it from?
Well, from my house to Tucson is about a 6 to 6.5 hour drive.
Yeah.
It takes me about 4 hours on a nice 4-lane highway to get to the border. But then we have that little thing called a border crossing. And I've done it in 15 minutes and I've done it in 3 hours. So we usually take the day to get up to Tucson, but if everything goes fine, it's 6 hours.
Okay.
The border is what makes it difficult.
Okay.
Could I ask Jerry a quick question? I don't
Yes.
know if all quests are the same, but I use a quest and they gave me a 0.03 for my last PSA. You think it's a different
Well, this
lab
is,
in Tucson?
yeah, I mean, it's a Quest lab in Tucson, but they only do 0.1.
Are you sure? Have you
yeah.
ever asked them? Not that you really need it, to be honest, but have you ever asked them if they do an ultra sensitive test? I mean, it could be that that's what the doctor's ordered.
Yeah, this, I didn't ask Dr. Rappiette if I could get a true PSA. Down here, they do a good PSA. It's really a good lab down here, and Dr. Rappiette knows about it, and so does Dr. Singh.
Right.
So,
let me just say, Jerry, that let me say that the tests are a regular test or an ultra sensitive test or an ultra sensitive test, and it all depends what the doctor puts it in for. So it may be that the order that they put in is for a regular test, which, to be honest, you don't really need more than that in your situation. So it makes sense, and a lot of times when anyway, I want to keep
really
moving
doesn't.
along.
Yeah, go right ahead.
Thanks. Thank you. Joel, you wanted a couple of minutes.
Yes, thank you. I had my first Pfizer vaccine last Thursday. I don't know much about RNA and what it does to your immune system, but is there a chance it's going to rev up my immune system and then kill more cancer cells while it's at it?
Well, that's a good question, and Moyad, Dr. Moyad, who some of you know, makes the point that the more vaccines you get, the more it revs up your immune system, so the better you are. So he's out there telling people you should get every vaccine that you can find. We've heard him say that more than once. I have to defer to either Len or Herb as to what their opinion is.
I don't think we have enough data to even think about it. I mean, certainly people who have had really strong immune reactions to it, and my physician at Georgetown was one of them, had a big fever, and so he knows it juiced up his immune system. But to be honest, if you didn't experience anything major, Joel, then chances are it didn't do anything.
Okay, no, I didn't experience anything at all except for soreness in the arm for about 15, 20 minutes, and that was it.
Right, that's how I felt.
Len?
Yeah, I was just gonna, I didn't hear everything Herb said, but I've heard Moyad say that several times before, like you, Rick. I don't know if it's true or not, but there's a difference between ramping up your immune system and getting the right specific immune response that you want. So let's say for cancer, I kind of doubt that it would have any effect, but don't really know. I don't think anybody knows.
Anybody else have any comment they would like to make about COVID?
All I know is that Moyad's a pretty outspoken guy. I know that. He's a colorful character.
He is. I'm quite interested. I'm very interested to see how everybody does when they get their second shot. Rick Medley's talking about Provenge. Rick, I strongly recommend you listen to this, to Saul Priceman. We'll make sure that we put out that link from the National Prostate Cancer State Prostate Cancer Coalition. because he talked at some length about today about Provenge, and yes, Provenge specifically, it kind of tailors your T cells to respond to your prostate cancer, and he explained how that is sort of different from some of the other therapies that they use that are similar. All right.
Hey, Rick, this is Mark
Yes.
Finn. Just real quickly, I had Provenge. I really have no concrete data whether it helped me or not. I mean, I'm still alive, so it helped probably in some way. The other thing is, for people who get at least the some of the COVID vaccinations, it's my understanding that the first shot's fine, which I've already had, and it's the second shot where the next day you feel like you have a hangover. So I just plan that when I get my second shot, I'm going to get really drunk. So if I feel like a hangover, I'll have a hangover.
There you go. All right, make it worthwhile, right? When are you getting that shot? Is it going to be before or after you learn whether you're in the trial, Mr. Finn?
It'll be before. I'm going to get the shot on Friday, so I'll have that completed.
Oh, well, let us know how you do. We'd love to hear. All right, Rusty, 2 minutes. Who's timing?
Okay, so I'm getting an MRI tomorrow, and I've been through a sonogram and an X-ray, but getting this bad boy checked out, and that popped up in just a few days. So it's some type of cyst. It's a paralateral cyst or a ganglion, I hope. But tomorrow, next day, I'll probably find out what it is and what we're gonna do. So it's not cancer related, I hope, but I just thought it was funny.
So what the hell have you got there? Like a large lump on the back of your hand? Is that what you're showing us?
No, here on my
it's on your
shoulder.
shoulder. Oh, wow. Oh, my goodness. Oh, geez.
So
And nothing to do with the lupus?
I don't know. I'm just a little worried because they did the X-ray, then a sonogram, and now an MRI. If it was a simple cyst, I don't think they would have done 3 different studies on it. So I'll find out in 2 days. I have a meeting with my rheumatologist.
Oh, man. Rusty, I think we gotta chain you up in your basement so you can't go anywhere and get. As soon as we let you out the house, you get sick again. What is going on here? Oh my God!
It's a gift that keeps on giving.
Oh Jesus Christ! I'm so sorry. Oh, it just is. Oh, just.
Well, this should be simple. So
Well, hopefully yes, and hopefully they'll tell you what it is, and well, let me know anyway. I don't know what to say.
Yeah, no, I'm fine. I'll let you guys know next week how everything comes out. Hopefully everything is.
Yeah, let me know before. Anybody have any thoughts for Rusty?
Rusty, you don't live by a Superfund site, do you?
By what?
You don't live by a Superfund site, do you?
No, not that I know of.
Oh man.
Junior Frankenstein.
Yo, God.
How's your hump? What hump?
Well, I've got a little lump like that in on my shoulder too, but it's nowhere near the size, and I've had it since I was about 15, and it keeps growing. It's from a rugby injury, but oh man, I just hope
this popped up within when I first felt it to when it became kind of this size was only about 4 or 5 days.
Okay. All right. Rusty, you stayed within your 2 minutes. You get to take you get another 2 minutes next time. That's the reward, man. Carl, tell us where you are in terms of deciding which trial you're going to go on.
Okay,
I'll try and talk fast. I was looking for a second opinion at Johns Hopkins. I asked for Dr. Denmead, Sam Denmead, and was told that since he's not licensed in the state of New Jersey where I live, I wouldn't be able to have a telemed appointment with him, but Dr. Carducci would be able to. So I have an appointment scheduled with Dr. Carducci. I don't know, I might want to cancel it. Okay.
I mean, Rick, I know you don't like him, but my experience with him wasn't that bad.
Well, I mean, we've had two people who have not been happy with him, so it's really your call. But we've had two people that have really not been happy with him, and I'm just passing that along.
Okay. All right. Well, it's for a second opinion. I don't know, but
yeah, but you know, I guess my bigger point is how many second opinions do you need here?
Well, that's what my wife is now saying. Yes, I'm getting too many of them. So
you know, keep on getting, and if you are going to get a second opinion, it's got to be from somebody who you know is exceptionally knowledgeable in making this comparison between an androgen receptor destroyer versus a bite trial. And I don't know that's, I mean, I'm sure Carducci's familiar, but you want one of these guys that, you know, you want somebody specific.
Yep. Well, I actually have an appointment, a telemed appointment with the head of precision medicine at Rutgers Cancer Institute. Hopefully he's going to shed some light on the situation. Also, Dr. Scott Tagawa's office had contacted me on Friday and gave me some preliminary instructions prior to a preliminary meeting or a physical prior to joining the ARV 110 trial. And I was told to get off of all my supplements, to stop my olaparib medication, and that the only two meds that I'm allowed to have with them is that I have sertraline, which I need to have for anxiety, and also a generic brand of Celexa. Those are the two, and everything else I was told to get off of immediately, and that within the next 10 days, that should give me some whatever detoxification of all those medications. But also I had a call this morning from Dr. Stein's office. I didn't get to speak to the person, but they also are now looking for me to proceed with them as well. So that's where I'm at.
Oh, Carl, I just going to echo what Rick would say, which is, you know, too many cooks spoil the broth.
Yeah.
I feel like you're going in all different directions. And
trying to cover all my bases. At least I hope so.
But you're not covering all your bases. You're confusing yourself, and you're giving yourself greater anxiety, Carl. Yeah. And you know, when you see these guys, then you've got to digest what they say. You've got to come back, and you know, we can help you digest it. But there's too much, and I think you've just got to you got to fish or cut bait here. And I agree with Herb. Anybody else, Len?
Yeah, I am thinking the same thing, Carl, that you're running around to all these different docs getting different opinions, and it's going to make it very difficult for you to make a decision. Yeah, I agree with Herb and Rick. Yeah.
Okay, thank you.
I mean, you've got two really good trials that you look like you can get into, the ARV 110 and the REGN 5678. If it were me, and I've said it before, I would go for the REGN 5678 because, you know, I heard Jonathan Simon he told somebody who called him up on this, I think it might have been Jerry Deans, he thought, it was Jerry Deans, he thought that was the single most exciting drug that's in clinical trial right now?
Well, at your suggestion, I did call up Mr. Simon's office. I had left a message for him to call me back. That was last week, so I hope he will.
Yeah, I didn't suggest you call Simons. I just told you what he said, and I doubt that he will. I mean, these guys are really, really, really busy. Unless you want to give him a $5,000 donation, and then maybe you'll get his attention. I'm serious.
Okay.
I mean, you know, how did Jerry Deans get in to speak to him? Through his contacts, through the fact that he was vice chairman of us too, et cetera, et cetera. But he's not going to just return calls to people. Unlikely. You may get lucky. But the fact is that we can tell you, he said he thought it was a great trial. Now, and you know, you've got these very different trials. One of them destroys an androgen receptor, but we don't know whether your disease works even works through the androgen receptor, because you're sitting there with a BRCA mutation, and the question to be asking these guys is, with a BRCA mutation, am I better off with a treatment that pulls a T cell into my cancer, or am I better off with a treatment that blocks the testosterone from getting to the cancer? I know what I think, just uneducated. Herb, well, I mean, you as a scientist have much better understanding, but these are such different methods of approaching disease.
I mean, I think, you know, they're both new trials. They're both early phase trials. So yes, they, in a certain sense, though, Carl, I have a feeling you're going to talk to people and you're still not going to know. You're still not going to get a clear picture. That's what I'm worried about. You get, somebody will say this and somebody will say that, and you'll have to weigh this by yourself. But I guess I would echo what Rick said. I think the Regeneron trial looked so promising as compared to other things. And I also think that, you know, the scientists, the chief scientist at Regeneron is one of the most brilliant people I've ever met in my life. So.
Anyone else have anything they want to contribute on this? The trial, somebody asked, the trial is the drug is REGN 5678. I don't know. I can't give you the trial number off the top, but if you put in REGN 5678 to clinicaltrials.gov, it'll come up with the BITE trial. The other trial is ARV 110, which is a drug that doesn't just block the androgen receptors, it's supposed to destroy them. Anyone else want to say anything on these two, or ask any questions on these two trials, two drugs, or say anything to Carl?
Carl, this is Peter. Did Dr. Munster ask you or invite you to join her UCSF e-gene study?
She had mentioned there was a particular trial available there, but she actually did recommend that I pursue the Regeneron trial, but that was before I even was concerning the ARV 110. And I also did email her back with a more specific question as to how to decide between the two, and I have not heard back from her.
No, this has nothing to do with trials. She's running a study. It's called e-gene, and I got an email from her a couple of days ago and joined it, filled out a form. It's just
no, she didn't mention.
Okay.
So, you know, Carl, and again, it's another thing, I've mentioned it before, you've just got to take it into consideration. But all these docs are, a lot of them are responding to you when they don't have to, you know, and so don't overstay your welcome with any of them. And it's not surprising they won't keep responding to you. You know, they do the consult with you, they charge you for the consult, but they can't they're not there to hold your hand. The doctor who's got to hold your hand is your guy whose name I always forget at the New Jersey Cancer Institute with an S. What's his name?
Oh, Soraya?
Soraya. He's your quarterback. He's your quarterback, and he's the guy you should be talking to and saying, which one should you go to? You chose him to be your quarterback?
I have posed the question to him, and it comes back to me as far as quality of life and which one I'm more comfortable with. So he's not specifically saying to me, and this has been my journey for the past 2.5 years with this disease. Every single doctor I talk to, they don't definitively tell me this is what you need to do. It always comes back onto my shoulders to decide what I want to do. It's very frustrating. I don't know if anybody else has had the same experience, but that's what I'm experiencing.
I think we all have, from the time when we had to decide whether we were going to do surgery or radiation, because so much of this is about quality of life and what you want to do. So in this instance, I understand from a quality of life standpoint, the ARV 110 is so much more advantageous, but it doesn't take into account the very specific nature of your disease, which is driven by a BRCA mutation. That makes you different from most other people, and you have to take that into account. So yes, some of it's quality of life, but the question I would go back to with Soraya is, with a BRCA mutation, Dr. Soraya, do you think it's going to make a difference whether I do the androgen receptor blocker or I do the BITE trial? Given that my cancer is driven not so much by testosterone, more by my BRCA mutation.
Okay, thank you.
Okay, Jimmy G. 45 seconds counting.
Oh, yeah. Okay. First of all, I'm going to use part of it to say to Mark Finn that Jesus does not get hangovers, so you must not be him. Because Rick, you called him Jesus at the first, and now he says he's going to go drinking after he gets his second vaccine. So I just want to clear that up. I'm only speaking because I'm only speaking because I got 5 medical visits in the next 4 weeks. And that's like, it would be overwhelming me, but I kind of don't mind doing what I got to do. But tomorrow I get PSA and testosterone. Then on the 12th, I get second vaccine. And the 23rd, I get a cystoscopy to see if I can have, no, I get a COVID test. Despite the vaccines, I got to get a COVID test. And the 25th, I get the cystoscopy to see if I'm good to get the artificial urinary sphincter. And if I am, I get that on the 1st of March. So I don't have anything to say. Everything's in front of me. I'm going to start only talking when the stuff's behind me so I can tell you how it went. As far as it's all in front of me, I'm the eternal optimist, so it's all going to go fine. And I'll just, take it like that. I don't like to take time for what's in front of me, but that's what I'm saying.
No, because you're raising a really important issue that we don't talk about that much anymore. And I didn't know that you were considering an artificial sphincter. We've had at least 2 men that have had artificial sphincters. Sadly, neither of them are still with us, but one of them had a really good and long run. Both of them were really happy with that artificial sphincter. So I think that it is a very good option. Is there anybody on the call who has any knowledge of maybe somebody in their group or their friends or anybody who has had an artificial sphincter?
See,
I considered it.
nada.
I went in and got assessed for it, but I decided not to proceed with it.
Okay.
That's the closest we'll have to any experience from Jesus. You see, the thing is, I look and I can't find any information on it. I can't find a lot of testimonials or reviews of it by people. Everything else, everybody's got something to say. Every other form of treatment I can find, patients' experience and saying if they like it, it works, it doesn't work. I just see a little bit about the sling, but the guy, the guy who's doing it said that I'm not sling material because I'm pretty much extreme case. And I can just tell you that if you don't have incontinence that's been going on since my prostatectomy, and it did not resolve, and the radiation kind of finished the job on me. And the quality of life issue from incontinence, especially when it's heavy like mine,
Yeah.
I'm not complaining. Let's just say it's quality of life issue, big time.
Yeah.
So I got all my diapers and I got all my pads and I got all my good attitude, and my wife won't get next to me and she loves me dearly. She says, you get that figured out, then we'll see what we can do, and I'm not bothering her. She's so good and understanding, but who can blame a wife for not wanting to get next to her husband?
No,
when
Jimmy,
she doesn't know,
I wanted
what's
to
going to
do
happen.
one thing though that I heard this week from somebody who had stage 3 bladder cancer and had to have a neobladder. That he told me that he got his insurance to pay for the pads, and that just happened recently. And it never even occurred to me, but it might be, and at least until you get there, it might be something you want to think about, because this is a direct side effect of treatment, and so it should be eligible. Peter, what did you want to say about this, Peter Kafka?
Yeah, I had a sling done when I had my prostatectomy, and I don't know what to say. I mean, I hear you. I hear the frustration and the challenge with your partner. I mean, that's big time. I mean, I was diagnosed and was on a catheter for 8 months, lying in the bed next to my partner. I mean, she put up with me for 8 months with a tube in my penis. It's crazy making. It's crazy making it, because it not only destroys your quality of life, but the quality of life of your relationship and everything. But there's
we're doing okay, but it's hard.
You can get through this. You can get through this, and maybe
Yeah, absolutely.
Here's the right move for sure.
Well, thank you very much, and I'm fine, really. But it's nothing is when I'm sitting, mostly I don't, because I'm so active. I'm always so proud to say I work out all the time. I'm in great shape. Well, the cost of that is the more active I am, the more the incontinence raises its ugly head. So I don't care. I'd rather be in shape and incontinent than the alternative. And I think that we should get Frank Fabish's insurance to pay for his plastic cutlery. That's what I think. That's more important than my pads. I got plenty of pads. I get them on the cheap.
Just real quickly, Jimmy, I don't know who's you're thinking about to do your surgery. I assume you're talking about a urethral cuff. And I do know and I don't have the name right in the head top, but I get it to you if you want. I went to the guy at the University of Chicago who's done quite a few of these, and he gave me some case studies and so on that I was very confident that it was a good procedure. The only reason I didn't proceed with it is I'm about a pad a day kind of incontinence, and it didn't seem to me.
A pad a day?
Yeah, I know that's not bad.
Punk.
I know, but
You're just a punk.
Yeah, I know. But anyway, yeah, I don't have to have a tray. I don't have to have a whole suitcase following me with all my pads. But
Right.
He had pretty good luck, and he was very, if you're a good candidate, they're very confident in what it can do. It's just for me, and also because I don't think with my metastatic disease that my life is going to be that long. I just didn't really want to. I didn't feel like I wanted to deal with one more thing. So.
Well, that's an interesting way to put it, but I don't know. You look pretty good to me, so I don't know.
Joel Blanchette and Peter Kafka. Joel has put in the chat window Dr. Leach, who I know Peter, I think, has had a consult with. Joel, what's your thinking on mentioning Dr. Leach?
Okay, I've heard about 3 of his briefings at PCRI, and he does those many a year. And so if I had to go get an artificial sphincter, I would definitely call him first.
Peter,
okay. Well, I got a guy, and I appreciate that, but I'm going to look at that.
Okay. And Peter,
Jimmy,
you've
where are you
seen
located?
in LA.
Washington, DC.
Tower Urology is in Beverly Hills. He's the urologist for the stars. Literally.
Who's in LA?
Leach.
Gary Leach.
Well,
Tower
I'm
Urology,
not.
right by Cedars-Sinai.
I'm in Washington, DC. I'm not flying out there.
Hey, if you want to get a penis for the stars, Jimmy, you got to go to LA.
I already got that. I got a piece for the stars. It's just, it's not shining brightly as it once did.
It's pointing in the wrong direction right
Get me
now.
out of
That's
here.
the problem. It's not pointing.
Move on. Let's end on that happy note. Yeah, there must be somebody else you want to get in here, please.
Okay, Jimmy, seriously, keep
We're
coming
moving on.
back to us because we do have some knowledge. And if we do find anybody, but I know that both Rob and Jim, once they had it done, were really happy with it. Rob in particular was very happy with it once he got it done. Okay.
Great. Thank you.
It's a pleasure. Who's on the telephone? We see somebody on the telephone there.
It's probably Dennis.
It could be Dennis. Anybody want to fess up to being on the telephone? Okay. Well, look, it's 8 o'clock and we've managed to get around everybody. I feel very badly that Fred and Lawrence and I think somebody else we didn't. Oh, Steve Linett. We didn't reach you as new men, but we will if you come back, and we will listen to your story and we'll give you as much time as we gave to the other guys. I think that's it. Next week's meeting is on the 9th. Yes, is on the 9th. Oh, yes, there is one other thing. On Wednesday at 8 o'clock Eastern, the active surveillance group, of which Jim Schrader is a moderator, is having a genetic counselor address the meeting. Once a month, they have a presentation meeting. And she is going to address the meeting and talk about genetic testing and going to take questions. It will be relatively general, but it will be prostate cancer specific. In other words, when I say relatively general, it won't only address active surveillance, it will be addressing prostate cancer in general. So everybody is welcome. I may send something out to everyone, but it is in this room, the Barniscus room, and it is on Wednesday at 8 o'clock Eastern. Did I get it all, Mr. Schrate, or should I say anything else about that?
No, I think you covered it, Rick. Sounds good. Looking forward to it.
Okay. All right, guys. I will thank you, everybody. Thanks for your participation. And all being well, we'll see you back in this room next Tuesday at 6 o'clock. I will do my best not to screw up the times on the reminder.
See you guys. Have a good week. Thank you.
Hey, take care, guys.
Bye.